and welcome to today's webinar. My name is Elena Sturman. I am the President and CEO of the Glaucoma Foundation. The Glaucoma Foundation, or TGF, was founded 40 years ago with a mission to encourage and support basic and applied research in glaucoma that may lead to the preservation and restoration of vision. The discovery of glaucoma genes almost 30 years ago sparked an increased interest in genetics and has improved our understanding of the physiological processes associated with the disease. Dr. Jenny Wiggs is one of the preeminent researchers in the field. Dr. Wiggs is a physician scientist at the Massachusetts Eye and Ear Infirmary and Harvard Medical School. Currently, the Paul Austin Chandler Professor of Ophthalmology at Harvard Medical School and Vice Chair of Clinical Research in Ophthalmology at the Massachusetts Eye and Ear Infirmary. Dr. Wiggs studies genetic risk factors for various types of glaucoma. She is the principal investigator of the NIH-funded Neighborhood Consortium, as well as NIH-funded study to identify genetic and environmental risks factors for exfoliation syndrome and exfoliation glaucoma. And she recently was awarded an NIH grant to study genetic risk factors associated with loss of central vision in glaucoma. Those of you who are scientists on our call, you know how hard to get those NIH grants. Dr. Wiggs is a member of the Glaucoma Foundation Scientific Advisory Board. She is unsurpassed in her field, and her CV is so extensive that I could barely cover it. Glaucoma Today describes her as a glaucoma visionary. In her talk today, The Role of Genetics in Glaucoma Diagnosis and Prevention, Dr. Wiggs is going to review how genetic information can help identify people with increased risk of glaucoma and how this information can help guide clinical care. As always, there will be a question and answer session at the end of the presentation. You can ask a question by using a chat button or Q&A button, and we will do our very best to answer as many questions as we can. Now, ladies and gentlemen, please join me in welcoming Dr. Jenny Wiggs, and let's begin.
So thank you so much for the introduction and also for the invitation to speak today. I'm really happy to share some of our recent work in genetics and glaucoma, and especially how we're using this information for glaucoma diagnosis and also prevention. These are some consulting arrangements that I have, which are not relevant to today's talk. So I think it's important to, first of all, really understand some features about the disease. And glaucoma is a relatively common cause of irreversible blindness throughout the world. The disease is caused by the fact that the normal production of fluid in the eye, which is normally made by structures in the front part of the eye, the normal production of this fluid is increased. Actually, what's really increased is that the fluid can't get out of the eye as quickly as it needs to, and that leads to a buildup of pressure in the eye. So the interesting thing about glaucoma is that just increasing pressure in the eye doesn't cause any symptoms or cause any problems to your sight. But what does happen when the pressure in the eye increases is that the optic nerve, which is a critical structure that connects the eye to the brain, becomes damaged. And the way that the damage occurs to the optic nerve is that the vision in the visual field, which is shown here on this slide, becomes gradually diminished. And so people lose their usually peripheral visual field first, and then over time, these visual field defects encroach on the center of the vision, and patients become absolutely blind. Now, a really important part of glaucoma care is to be able to identify people who are at risk for developing glaucoma before this irreversible damage to the optic nerve occurs. And that's so important because once the damage to the nerve occurs, There's nothing we can do to bring it back. Once that nerve is damaged, it will stay damaged, and we can't do anything to improve sight. However, if we know that somebody is destined to have that damage, then we can initiate treatment for the disease at very early stages of disease when the treatment is more effective, and also when we can prevent then or slow down the process of the disease, reducing the amount of damage that is causing the decreased vision because of the optic nerve. So it's really critical. Our whole approach to taking care of glaucoma patients is to try to catch people at the earliest stages of disease when we can initiate treatment and have the best outcomes from the treatment that we initiate. But a major problem is finding people at that early stage of disease. And that's because it's very difficult to use our current techniques of measuring intraocular pressure and doing the kinds of imaging that we do on the optic nerve on a population scale for screening. So what comes to the rescue then is glaucoma genetics. So how can genetics help? Well, first of all, most types of glaucoma have strong heritability, which means that there are genes that you carry in your body for your entire lifetime that can influence your risk of developing this disease. And these genes that cause or contribute to glaucoma can be used then for genetic testing really at any point in your lifetime, because your genes don't change your entire lifetime. And this genetic testing can identify people who are carriers of mutations or changes in DNA that influence or increase the risk of developing glaucoma. When we identify people who are carriers of these risk variants or mutations, then we can do things to help them. We can increase surveillance for disease, so we can really target all of our imaging that we use in the clinic and all of our tools to follow these patients and make sure that we really start treatment at very, very early stages. And then, of course, once we see any sign of damage or any concern about the disease developing or progressing, we can initiate therapy at that point. And in some cases, we can tailor the type of therapy that we're starting to the disease risk. So people who have a very, very high risk of disease, we could potentially employ more aggressive treatment strategies than people who have a milder risk of disease. So that's why we study genes, and that's why we study genetics of glaucoma, because we want to find these genes that we can use then for genetic testing so that we can identify people who are at high risk for disease. Now, what's important to understand about glaucoma is that it actually affects individuals across the lifespan. So there are types of glaucoma that affect babies. These are, the types congenital glaucoma, juvenile onset, primary open-angle glaucoma that affects children. There's a class of diseases called developmental glaucoma. And then in the adults, we have the diseases, the primary open-angle glaucoma, which is very common, angle closure and exfoliation glaucoma. So the early onset forms of glaucoma, the childhood forms of glaucoma, are relatively rare in populations, but these are very severe types of disease. So these are mutations that have very large effects on patients' risk. So you have one of these mutations, you're highly likely to develop disease. These mutations are passed on usually in families. So families can have more than one affected person in the family. And traditionally, we used kind of classic genetic techniques to find these genes. Now we're using sort of more up-to-date approaches like whole exome and whole genome sequencing. And we have currently 12 known causative genes for these childhood type glaucomas. In contrast, the adult onset diseases have what's called complex inheritance. So what that means is that there's not a single mutation with a very large effect on the disease risk. There are many variants that are relatively common in populations that have smaller effects. But in aggregate, if somebody has a lot of these small effect variants, then the disease threshold can be reached. This kind of disease is usually studied in cases and controls and using genome-wide association studies. And we have more than 100 now associated genetic variants. Actually, we have even more than that now that are influencing the risk of the most common of these complex diseases, which is primary open-angle glaucoma. So I'm going to talk briefly about how we can use genes for genetic testing, both for the early onset types and for the adult onset types, to understand, kind of the modern approach now of using genetic testing to identify people at increased risk of disease. So I'm first of all going to give you an example of how we use genetic testing for early onset families. So families who have disease, when they're children or even young adults. So this is an example of one of these families. This is a pedigree where we identify women as circles and men as squares. I can make a joke about that, but I won't. It's hard to make jokes on Zoom. So, but this woman came to me in the clinic, and she was diagnosed at age 20 years before with a very severe type of glaucoma, and actually ended up having to have surgery for her glaucoma. Subsequently, she has had children. She's had 4 children, 2 boys and 2 girls. Her oldest child, an 18-year-old boy, shown there in the square with the 18, had recently had an eye exam for glasses and had noted that the provider had noted that his pressure was slightly elevated. Normal is usually 15 to 20 or 21, and his pressures were 22 and 23. Looking at his optic nerves, they still looked healthy and normal, but there was concern that she might have passed on a mutation to this boy. So we did genetic testing for this whole family. And what we found is that indeed she had a mutation in a gene known to cause early onset glaucoma. It's called myocilin. So she had a myocilin mutation. And indeed, she had passed that mutation on to her 18-year-old son with a slightly elevated pressure. She had also passed that mutation on to her 9-year-old daughter at the very end of that diagram there. And and the 2 middle children didn't have the mutation. So how can we use this information to benefit this family? Well, first of all, given that the 18-year-old already has slightly higher pressure and has, the mutation that she had also early in life, we could consider at this point starting treatment to lower his intraocular pressure and keep his optic nerve healthy for as long as we can. Also, the 9-year-old daughter, needs to be watched carefully. She also needs to be aware that she has a great increase in likelihood of developing glaucoma, and we want to be able to treat her also at the earliest sign of any kind of disease. And importantly, the 2 children in the middle of the family, they don't have this mutation. And so there's no reason to be concerned about them at this stage of their lives. Their risk of developing glaucoma at this point is no different than the general population. So this kind of genetic testing can be super useful for families like this. It's greatly reassuring to them to know who has the likelihood of developing disease, who needs to be followed, who doesn't need to be followed, who needs to be treated, and it's and to give some insight into why they have glaucoma in the family. These are the genes that we can currently do genetic testing for these early onset forms of glaucoma, which can be very, very helpful for the families that carry mutations in these genes. Unfortunately, a problem that we have with the early onset glaucoma families is that currently these genes that we know about only account for disease in about 20% of patients. So about 20% of the time, when a family comes into us for genetic testing, we find a mutation, but 80% of the time we don't. And what that means is that we just haven't done enough work yet to discover all the genes that cause these early onset forms of glaucoma. So we're doing a lot of research, a lot of work in the lab right now to identify new genes. We're using current state-of-the-art approaches, whole genome sequencing, and we've also expanded our search from sort of typical US populations to more ethnically diverse populations, because that can help us identify genes and mutations that might be missing in the populations that have been analyzed previously. And using this approach, we have recently, in the last couple of years, found 2 new genes for these diseases. So we are making some progress here. All right, so now let's shift our focus to the adult onset types of diseases like primary open-angle glaucoma, or POAG, which is in fact the most common type of glaucoma of all the glaucomas that we care for in the clinic. And just to remind you, this, unlike these early onset diseases, this disease has what we call complex inheritance, where somebody's disease is not due to a single mutation, but it's due to an accumulative effect of many disease variants. So how does that work in terms of testing? Well, when you think about the early onset disease, where a single mutation is enough to tip the balance from health to disease, you only need to test for that single mutation and you can accomplish your goal. For these adult onset diseases, testing for a single mutation doesn't give you very much information, and only in aggregate can you assess the risk of that patient in terms of developing disease. So it makes way more sense for us when we're doing genetic testing for these adult onset diseases, not to look at a single variant or genetic risk factor one by one, but to look at the combined effect of many of these risk factors at once. And we do this through something called a risk score, where we test a number of variants and then just simply calculate how many variants an individual has. So in this case, we looked at a panel of 15 variants. This woman had 6 of 15, and that was her score. Now, in recent years, there have been really useful bioinformatic techniques to be able to calculate the risk effects of thousands of genetic variants that predispose to these diseases. So when we do a typical genome-wide association study, which I've shown here on this slide, we get thousands of variants. We identify thousands of pieces of DNA, thousands of DNA segments that contribute to disease. What we can do with the polygenic risk score is we can look at all of those in an individual to calculate a very comprehensive number that assesses their risk. So we sum all the risk variants that we identify in this study in every person that we're interested in looking at. We sum all of those risk variants, and then we rank that person in their population according to how many risk variants they have. So some people, are going to have a lot of those. They're going to have many, many risk variants, and they're going to be in the 90th percentile. Some people are going to have just a few of those variants, and they're going to be like in the bottom of the distribution. A lot of people are in the middle, and as you might expect. But what we have found is that people in the highest percentiles, the people with the most risk variants, of course, have the highest risk of disease compared to those in the lowest distribution. Now, what we wanted to do is what we wanted to find out is we really wanted to answer this question: what is the clinical impact of having a high polygenic risk score? In other words, what is the clinical outcome of having the largest number of genetic risk variants that puts you in the top 90th percentile of the polygenic risk score. Specifically, we wanted to know, is this a useful risk stratification tool? If we calculate polygenic risk scores for a whole population and we identify those people at the very top, do they really have more glaucoma? Do they have more severe glaucoma than the people at the bottom of the distribution? Can we use this score to identify people that haven't been diagnosed with glaucoma? In other words, can we use this score as a screening test to find people who have high genetic risk of glaucoma, which is a very important part of clinical care, as I mentioned earlier? And what are the clinical features of these people with high polygenic risk scores? So Dr. Lou Pasquale and I came up with an idea to evaluate the clinical impact of these high polygenic risk scores. And what we did is we calculated the score for primary open-angle glaucoma, the glaucoma PRS score. We calculated this score in a very large number of people from the hospital that I work at, which is Mass General Brigham, and the biobank there includes about 45, 50,000 people. And then we also calculated the score for the hospital where Dr. Pasquale works at Mount Sinai in New York City. We identified the people who were in the top and the bottom of this polygenic risk distribution, and we invited them into our clinics at our respective hospitals for a comprehensive exam to see what they really had. So this is the exam we did. We did a full clinical exam on every person that came into our clinics, measuring their vision, their visual field testing. We did optic nerve imaging. We looked at them normally as we would do for any patient that we were wondering if they had glaucoma or not. And we did all of this masked to the polygenic risk score. So when we were examining the patients, we didn't know what their score was. And only after we decided if they had glaucoma or not, did we find out their score. So we were completely masked to the score during the examination, which is good practice for this kind of study. So what did we find? Well, the most striking result that we found to start with is that people in the high polygenic risk score group were much, much more likely to have glaucoma, 35% on average compared to less than 10% in the lowest group. So indeed, people with high polygenic risk scores are much more likely to have glaucoma. And this was true at both the New York site at BioMe and also at the Boston site for the Mass General Brigham Biobank. We also found that this was true of all the ancestries that we tested. Most of our subjects at both sites were European ancestry, and admittedly our numbers are a little underpowered for some of the other ancestral groups, but in general, we found the same relative prevalence for all the ancestries that we looked at. So the test works well for European ancestry people, but also likely other people as well. I think the thing that is most exciting and really, really important is that of all the people that we identified that had glaucoma with the high polygenic risk score, 50% of them were previously undiagnosed. So these are people who were just walking around with glaucoma and didn't realize it. The only reason they were diagnosed with glaucoma is because they enrolled in our study and we calculated their polygenic risk score and called them in for an exam and made the diagnosis. So that's really important for those people, but also it's really important because it shows that we can use this score really as a screening test to identify people who are at high risk for disease, but also people who have disease and don't realize that they have it. So to summarize this clinical study, individuals with high polygenic risk scores are more likely to have a diagnosis of glaucoma compared with low scores. And 50% of the individuals with these high scores in glaucoma in our study were previously undiagnosed. We made the diagnosis based on the polygenic risk score and their clinical exam. Individuals also with high polygenic risk scores are more likely to have clinical features of glaucoma. I didn't show you all of this data today, but including higher intraocular pressure, some other corneal features associated with glaucoma, and lower values on visual field testing. So where does this stand then in terms of what we can do for genetic testing in glaucoma? Genetic testing using early onset glaucoma genes identifies carriers of high impact mutations, allowing for early surveillance or overall surveillance and early treatment, as I indicated with the family example that I showed you. Genome-wide association studies have identified hundreds of, really thousands of POEG risk variants. And using those variants, we can create these polygenic risk scores to define people at high disease risk who have more severe disease and with earlier onset. So in addition, using the polygenic risk score as a screening tool, pre-symptomatic polygenic risk stratification can allow then for early detection, increased surveillance, early detection, and earlier treatment of patients who are destined to develop this blinding disease. We have in this field a lot of work still to do. It's been extremely exciting to have had this kind of progress in the last 5 and 10 years, really in the last few years, but there is still so much work to do to be able to offer comprehensive genetic testing for all of our patients. In particular for the early onset families, with the children, we still need a lot of new gene discovery. We're missing a lot of genes there, and we're doing a lot of work to improve that, both from working hard on understanding what we know about our current genes and variants, but also doing whole genome sequencing and looking at more complex effects that result from those kinds of results. And in the polygenic risk scores, I think we're making really a lot of progress in terms of where we're going with this testing. It would be great to have a better understanding of how patients and providers respond to information about polygenic risk scores. We've devised a study to assess using a simple questionnaire how patients who receive their polygenic risk scores, how they feel about that information, and then also for providers to understand how providers are using these scores potentially for modifying their approach to treatment. We'd also like to know a lot about whether there are factors that can modify polygenic risk. Are there things that can protect people with high polygenic risk from developing disease? And are there risk factors that cause disease independent of the kinds of factors that we look at with these scores? And we don't yet have a really good understanding of how polygenic risk scores are potentially transmitted to other family members. We understand a lot about how single mutations and severe early onset disease are transferred to family members, but we don't understand the mechanism through transferring of high polygenic risk scores and whether in fact that even happens among families. I just wanted to end with one slide kind of discussing recommendations for testing, and this is something that I'm always asked. So it's almost like starting the conversation around this, but I usually recommend genetic testing with the early onset glaucoma genes for patients who have disease onset before age 40. That's really our highest yield in terms of finding mutations in the genes that we currently know about. And it's also then, potentially useful if we find a mutation in those individuals, then we can test people in their family. So genetic testing using polygenic risk scores for adult onset glaucoma is really just coming into the clinical space. There is a 23andMe polygenic risk score test available that that you pay for. It's a couple $100, I think. And we, in our glaucoma service, and in our genetic testing service at Mass Pioneer, we are developing a new genetic test for all of our glaucoma patients, early or old or older, that will test for the early onset glaucoma genes and the polygenic risk score at the same time. And that test will be coming out soon. We're targeting it first as a research study for people in our clinic, but we'll be hopefully offering that as a test for the community, and I'm sure other departments will also adopt similar testing in the future. And a point that I really want to make is that for all of these genetic tests, genetic counseling and provider consultation is really important. So, one of the problems with getting genetic testing, say at some place like 23andMe, is that, you send in your sample and the report comes back, but there's not a lot of one-to-one counseling with you, the patient, on what that test means. So, and what it means to your family and what the next steps should be, in both in terms of kind of informing people about their risk, but also in terms of understanding how the disease will be treated, which comes from the provider. So it's really important to be able to not have this information in a vacuum, but have it interpreted by people who understand the reports. And with that, I just want to acknowledge a lot of people who work on this. These are all the members of the International Glaucoma Genetics Consortium. You can see there are many people. This is what led to some of the very large genome-wide association studies that made it possible to develop a polygenic risk score. And these are people in my lab and also people that collaborate with us on specific projects. So thank you very much. I'm more than happy to answer questions.
Thank you so much, Jenny, for this absolutely brilliant presentation. There are questions, and you were right. A lot of them are about where to get the testing. So I'm just going to start. I have glaucoma, and so do two of my sisters. What testing should our children get other than regular eye exam to try to detect if they have glaucoma as early as possible?
Yeah, so that's a really great example. And it's important to know how old you and your sisters were when the glaucoma was diagnosed, because that really determines what kind of test is done. So if you were before age 40, if it was diagnosed before age 40, then you would want to have testing that included the early onset glaucoma genes. If it was after age 40, then it may be useful to consider polygenic risk score testing, even 23andMe, but to be sure that you have someone who's knowledgeable that can help you understand the results of that test. And going forward, not probably for a year or so, but when we have our blended early onset glaucoma, adult onset glaucoma test, that's an ideal test for families like this, because we'll be able to cover the whole landscape of the genes that can contribute to glaucoma.
Thank you very much. Next question. How does a member of the general public get their polygenetic risk score measured to determine their glaucoma risk other than 23andMe?
Other than 23andMe? So yeah, right now, I mean, it's a very rapidly developing field, and there are other companies that are being formed around doing this kind of genetic testing. You know, our colleagues in Australia actually are working on a company there that will offer, you know, polygenic risk score testing. But right now, there aren't a lot of other, you know, other than 23andMe, there aren't a lot of other opportunities for that kind of testing. And it's coming, you know, it will be, you know, it will be available soon. So, you know, I do think it's going to be really very important. And I anticipate that, and I think others as well, but that it really will become part of our clinical care in the glaucoma service. So if somebody comes into the service, you know, just like we do vision testing and visual field testing and all the other things that we do for a new patient, this would be something that we would do. We would get this number for the polygenic risk score. And I think it will help guide our approach. But yeah, for right now, you know, a lot of that is not available yet. So coming soon.
Thank you very much. Next question. Does polygenic risk score apply to normal tension glaucoma as well?
Now that is a really good question. And I don't have the answer to that yet. It's partly because we don't have a comprehensive list of genetic variants that influence development of normal tension glaucoma. So it's something we're working on actually right now in our research. We're completing a GWAS, a genome-wide association study for normal tension glaucoma. We're very interested then in calculating a polygenic risk score for normal tension glaucoma based on those genetic variants. And you know, that may be rolled into the other polygenic risk scores that we have, or it may be that we'll test separately for normal tension glaucoma. It depends a little bit on how those results pan out. But yeah, that's a really important topic, and we're still working on that.
Thank you very much. Next question. How long does it take for this information to trickle down to your typical ophthalmologist or glaucoma specialist?
Well, all the ones that work with me, it takes no time at all. You know, this is all they hear about 24/7. You know, I think that I think that our field is doing a really good job communicating this information. We do it, I mean, I give countless talks, you know, all the time, and my colleagues do as well. And you know, our goal is to educate the whole community. I mean, from patients to providers to students, you know, really, it's really important to get this information understood by the whole, you know, everyone who's involved in this. You know, and I think it depends a lot on how receptive people are to change and how much they understand, you know, what the scores really mean. But, you know, I have to say that even in the last few months, I feel that, you know, people are understanding it more and more. And I think it will become, as I said, I really think it will become a tool that we use regularly in the clinic.
Thank you very much. Next question. Is this test valid for exfoliation glaucoma, and can you talk a bit more about it?
Okay. Yeah, so that's another really great question. And exfoliation glaucoma has its own set of genetic variants that are not part of the genetic variants that influence the more common primary open-angle glaucoma. So it really doesn't impact exfoliation glaucoma directly. This is a little bit complicated, but the genetic variants that contribute to the exfoliation glaucoma, we think that they contribute to the condition, but not necessarily to the glaucoma susceptibility, because there are many people who have the condition who don't have glaucoma. And so one of the things that we would like to look at is whether in the people who develop exfoliation glaucoma, so not just exfoliation, but exfoliation plus glaucoma, do they have high polygenic risk scores based on the current testing? We've done a couple of experiments looking at that, and I think it's possible that that will be the case, and that could be important for people with exfoliation syndrome, but it's kind of right at the edge of the research, and we have a little bit more work to do there to be confident about that.
Thank you very much. And this is the last question, and I think it's a very appropriate question to ask at the end of this presentation. When do you expect use of polygenic risk score to become part of the standard of care in ophthalmology or even family practice?
Yeah, so so for glaucoma, it's really important to know what your risk is before the disease becomes manifest, because once you have the disease, there's nothing that can be done about bringing back the loss of vision. So our whole game in glaucoma is to identify people at risk at early stages of disease. And so this is an ideal opportunity, to use something like a polygenic risk score, which will identify people who are predisposed to disease before they ever get disease, in fact. So that's as early as it can be, which is fantastic. So for a disease like glaucoma, where there is treatment that's pretty good that we can use once somebody does develop disease, it makes a lot of sense to know that you have a high risk for that disease. Not every disease is like that. So for some diseases where there may not be good treatment, good preventative treatment, then understanding your genetic risk for that disease may not be as helpful. So polygenic risk scores are not perfect for every disease, but obviously for something like glaucoma, it's very important. It's very important for diseases, cardiovascular diseases. Polygenic risk scores for myocardial infarction or heart attacks, have a very strong predictive effect. They can identify people at high risk for these events, these cardiac events. And that's very important because you can employ, statin lowering medications, you can advise about weight loss, stopping smoking, all of these kinds of things that influence that disease risk. So, it's another example of where polygenic risk is really important. For cancer, a number of cancers, polygenic risk scores are very important. They identify people who are at high risk so they can have also early surveillance and early treatment. But it really depends on the disease. And a key thing is that early surveillance and early treatment is valuable, and that there is treatment available that can be employed to at least slow the disease.
Thank you very, very much. We've come to the end of our webinar. I would like to thank Dr. Wicks so much for this insightful and really brilliant presentation. I would like to thank our audience for participating, for listening. This webinar will be available tomorrow on our website and on our YouTube channel in case you missed something and wanted to listen to it again. Again, many thanks for participating. Many thanks, Dr. Wicks. And stay connected to the Glaucoma Foundation and have a wonderful evening.
Thanks.
Good night, everybody.
Thank you.
Bye.
Bye.